Hello, everybody. I am Professor Leonidas Duntas at Eugenidian Hospital, National and Kapodistia University of Athens. I'm endocrinologist, and I'm working on thyroid, mainly on clinical thyroidology. My interests are treatment of thyroid diseases and the effects of nutrition and environmental factors on thyroid function, particularly on autoimmune thyroid diseases.
Can you outline for us, please, how to manage a patient starting levothyroxine therapy for the first time?
Yes. First, treatment for hypothyroidism has evolved greatly over the past 140 years, advancing from the first attempts via transplantation of part of a sheep's thyroid gland under the skin on each side of the inframammary region to desiccated thyroid extracts and to the availability of various formulations of levothyroxine, such as tablets, soft gel, um, even liquid forms during the last 50 years. A highly successful advancement in medicine, stretching from the past into the present and from the present into an ever better future. Levothyroxine, due to its half-life of about 7 days in euthyroid state, is the preferred first-line treatment for hypothyroidism. It has been the most common prescribed treatment since the 1980s, one of the most prescribed medications in the world, and is on the WHO model list of essential medicines. The levothyroxine dose initially required by a patient depends primarily on three factors: the amount of residual thyroid function retained by the patient's body weight or lean body mass, and the target thyrotropin stimulating hormone level to achieved during therapy. Additional factors such as patient age, sex, and menopausal status may have an influence that is generally of lesser magnitude. Also, other physiological factors such as pregnancy and gastrointestinal functioning may be important factors in specific patients or at specific times. When commencing levothyroxine therapy, initial dose requirements can greatly vary from small doses such as 25 to 50 micrograms a day in an individual with mild or subclinical disease, in whom the therapy may be supplementing endogenous thyroid function, to larger doses of 88 to 175 micrograms a day in cases of patients with negligible endogenous thyroid function. The dose requirement in those with hypothyroidism or with Hashimoto thyroiditis and post-surgical hypothyroidism is approximately 1.6 micrograms per kilo a day. The dose of a patient following thyroidectomy can be predicted by either body weight or BMI. Various formulas have been used to calculate the doses requirement, and this range simply formulae based on body weight or more complex based on TSH and also other factors such as patient sex. However, people with hypothyroidism need to take the drug for a long time, often for the rest of their lives. Therefore, it is important to monitor the patients and closely monitor the patients and the dose adjusted for the best effect.
What adjustments would you make to standard care for an obese patient and for an elderly patient?
Yes, hypothyroidism and obesity are closely related conditions because hypothyroidism is associated with decreased resting energy expenditure and thermogenesis. An increased prevalence of subclinical hypothyroidism has been reported among obese patients. Data from China, which have been multivariably and logistically have been analyzed with multivariate logistic regression analysis, show that metabolically unhealthy individuals with and without obesity had an increased risk of subclinical hypothyroidism as compared to metabolically healthy individuals without obesity. LT4 treatment should be initiated when obese patients, especially young subjects and women of reproductive age, are diagnosed with thyroid autoimmunity associated with subclinical hypothyroidism, or when other causes of primary hypothyroidism, for example, a prior partial thyroidectomy or history of destructive thyroiditis, are identified. According to some reports, L-thyroxine doses for obese hypothyroid persons must be higher than those for normal weight. The latter may be explained by several factors, primarily as a faster rate of LT4 treatment, the presence of a higher distribution volume, and the potential delay in LT4 absorption via the gastrointestinal tract as a result of coexisting inflammatory diseases, Helicobacter pylori, or gastritis. Some obese patients receiving levothyroxine replacement therapy at the standard dose of 1.6 micrograms per kilo per day are possibly being overtreated, even with periodic biochemical monitoring according to other research studies. These findings point to the need for the LT4 dose to be determined based on the obese patient's BMI. BMI is important so to calculate the dose and also for the monitoring of the patients. Now, concerning age, for patients who are elderly, that is over 65 or over 70, have concomitant cardiac disease or may have had long-standing untreated hypothyroidism, it is wise to initiate a levothyroxine treatment, low dose, or such as 25 to 50 micrograms a day, and increment slowly the dose to full replacement to avoid precipitating cardiac ischemia. However, regardless of the method used to estimate the initial levothyroxine dose, requirement of dose adjustment is frequently required. In elderly patients with subclinical hypothyroidism, should be considered individually according to the patient's age, serum TSH, and hypothyroid clinical symptoms, concomitant cardiovascular disease, or risk factors for cardiovascular disease, and taking into consideration also other comorbidities. However, it remains that studies should be organized to elucidate the impact of subclinical hypothyroidism on cardiovascular disease. And these studies should be conducting by considering age-related reference ranges.
Please explain why it is difficult to achieve a euthyroid state for patients needing levothyroxine therapy.
We must consider
Debemos tener en
thyroid
cuenta la
hormone
homeostasis de la
in
hormona
the brain,
tiroidea en el cerebro, que es
which is
única.
unique. For example,
Por ejemplo, el 50% del
50%
contenido de
of
T3 en el cerebro
T3
procede
content in
del
the
plasma
brain
y el otro 50% se genera localmente mediante la desyodación de T4 a T3 a través de la yodotironina desyodasa de tipo 2.
through the deionization of T4 to T3 via the type 2 iodothyronine deiodinase.
El tratamiento con LT4, que normaliza las concentraciones de TSH, también produce un aumento de T4 libre y una disminución de T3 libre en las concentraciones séricas.
In the serum levels.
Esto podría afectar hasta al 47% de los pacientes, quienes podrían presentar un aumento de FT4 por encima del intervalo de referencia, y hasta el 50% muestra concentraciones de FT3 por debajo del intervalo de referencia.
50% of the patients showing FT3 levels below the reference range.
Lógicamente, la reducción de T3 en plasma compromete su contribución a la generación de T3 en el cerebro. Sabemos que las neuronas absorben y empaquetan T3 en endosomas, que luego se transportan de regreso al núcleo celular, donde T3 regula la transcripción génica. Una disminución de T3 en plasma podría, en teoría, compensarse mediante un aumento homeostático de la vía de D2, lo que conduciría a un aumento de la generación local de T3. Sin embargo, es poco probable que este mecanismo se active en pacientes en tratamiento con LT4 debido a sus elevadas concentraciones de T4 libre. Otro mecanismo es la inducción de la ubiquitinación por T4 y también la degradación proteasomal de la desiodasa de tipo 2, lo que limita la producción de T3 a través de esta vía.
Which limit T3 production via this pathway.
La función de la ubiquitinación es eliminar las proteínas disfuncionales o mal plegadas a través de los proteasomas, y estas funciones específicas permiten que la ubiquitinación regule la calidad de las proteínas en las células.
The ubiquitination to regulate protein quality in cells.
What is the role of T3 in the persistence of hypothyroidism symptoms in some patients?
Well, we know that about 15 to 20% of patients treated with monotherapy have persistent symptoms and complaints. This prompted investigation into the possibility that combination treatment with a synthetic thyroxine and triiodothyronine, T3, or with a natural occurring porcine thyroglobulin, which is contained in the desiccated thyroid extracts, might be more effective than LT4 alone. Approximately 20 randomized double-blinded clinical trials were conducted to explore this hypothesis. The randomized studies, which spanned several months, consistently demonstrated that LT4 and LT4 plus LT3 treatments were equally effective based on patient reported outcomes. Consequently, expert groups tasked with drafting clinical guidelines reasoned that the inconvenience of taking two daily tablets, along with the associated cost and effort required for implementing and monitoring combination therapy, outweighed any potential benefits to patients. Additionally, theoretical concerns regarding the long-term safety of combination therapy were raised based on the rapid absorption and clearance of T3 from plasma, leading to a transient peak about 3 hours with a magnitude that varied with LT3 doses. Nonetheless, evidence for worse adverse effects is lacking to this treatment, such as questionnaires evaluating quality of life, mood, and cognition.
The gut microbiome is increasingly implicated as an influence on thyroid function. What are your thoughts on this?
We know that thyroid and intestinal diseases prevalent coexist. Hashimoto thyroiditis and Graves' disease, the most common autoimmune thyroid diseases, often co-occur with celiac disease and non-celiac wheat sensitivity. This can be explained by the damage of the intestinal barrier and the following increase of intestinal permeability, allowing antigens to pass more easily and activate the immune system or cross-react with extra-intestinal tissues, respectively. Dysbiosis has not been found only in autoimmune thyroid diseases, but also has been reported in thyroid carcinoma, in which an increased number of carcinogenic and inflammatory bacterial strains were observed. Additionally, the composition of the gut microbiome influences the availability of essential micronutrients for the thyroid gland. If the intestine is not properly working, then we have reduced availability of micronutrients to thyroid. We can consider the gastrointestinal tract as the port of thyroid gland. I'm happy to participate in this interview, and therefore I would like to warmly thank Medea and particularly Flaminia Masprone for the review invitation.